Governor, Deborah Watson, who joins us as the elected representative of Bolsover District Council. We're particularly pleased to have you around the table, Deborah.
Thank you.
We have a number of, I did say in our informal session, Deborah, that I had high hopes of you making a fabulous contribution, because any woman who can juggle the lives of 8 children will find juggling diary commitments to make a good contribution to CoG and walk in the park. So your reputation is now preceding you as you join the Council of Governors. So a particularly warm welcome. We've got a number of apologies, not least reflective of the fact that we're in the middle of holiday season. So I'm just going to go across to Nicola to share those apologies with us.
We've had apologies from Anne Margette, Greg Strachan, Frank's going to be a little bit late, Mick Portman, Fiona Wilson, Angie Smithson, Zoe Linton, John Thorpe, Alison McKinnon, Sue Glue. That's it.
Very good. Thank you very much.
Helen, sorry, can I?
Sorry, who was that?
It's on today. I'll leave tomorrow. It's Zoe Linton. So I am here.
Oh, hello.
Oh, you are here. Sorry,
I am here. Sorry, my leave plans have changed and now starts tomorrow.
Oh, I'm so sorry.
Didn't know.
Yes, and Tony's a little delayed joining us. He's in a meeting, but we're expecting him well in advance of the Chief Exec's briefing.
I'm with you, Helen. I'm with you.
Right.
Yeah.
Thank you very much, Tony. I think Norman might be having problems with sound, Nicola, so I don't know if you'll be able to have a conversation with him via text or something to see if there's any support or assistance we can give him in that regard. Thank you very much. Also worth reminding everyone that this meeting is being recorded, as we have with all the live stream meetings. For those who are unable to join now, that there's an opportunity for them to see it either on the Trust website or on YouTube. So just to make you aware of that. That takes me on to declarations of interest. Are there any changes to the register of interest or any particular declarations in respect of today's business? And if you could indicate on the chat, if that's the case, I will be grateful. Whilst I'm waiting for any notification from colleagues, I might just point out that I stepped down this month as the chair of the board of Mount St Mary's and Barbara Hall Schools and the associated charity trusteeships I held in that respect. So that's a change to the register to be noted, please. I don't think there's anybody else advising of changes to the register or declarations. So that takes us to verbal questions from the public. I'm not quite sure how many members of the public we've got on the line, but if any of you are on the line, you're very welcome. And it's we always have this opportunity for members of the public to ask questions now. But that said, given the circumstances, we appreciate that things might come to light for you during the meeting where you'd like the opportunity to ask a question. So Kate Brooks, who's in charge of technology today, will be able to see those questions and will be able to relay them to us as they arise, and I will revisit those at the end of the meeting. So if there are members of the public on the call, don't feel obliged to speak now or forever hold your peace. There will be an opportunity for you to join later and have those questions addressed. So it wouldn't appear that we've got any just at the moment. So I think just a final few introductory remarks from me, if I may, before we go to the Chief Exec's report. Which is to say that our thoughts are with all of those in the Trust who have died of COVID or COVID-related complications during the last few months. Our last COVID-related death was on the 10th of July, bringing the total number of deaths at the Trust to 138. But obviously, I'm very pleased to say that we've had almost 300 people who presented with COVID-related conditions and declared medically fit for discharge. But I appreciate how difficult a time that makes it for families across our community, and indeed the toll that takes on staff of caring in that very intense way for people at a particularly vulnerable time. Renewed and continued thanks to each and every member of our staff. I had the pleasure of doing a virtual visit just to show that it can be done virtually with Angie, our Chief Exec, with Beverly, the Deputy Chair, and with Maxine, who is the matron of ITU and HDU. And we learned lots of interesting things about how the last few months have been handled. But the fact that will stick longest in my memory is the fact that the nursing rota for those units is normally 60 strong. And because of the arrangements we put in place during COVID, that rota had to be increased to 160. And the difference of those 100 nurses were all volunteers. So we didn't have to ask anybody from anywhere else in the trust to, come and respond to that very real requirement. They were all willing volunteers. And I think that just goes to show the whole spirit of a team and great support there has been for colleagues towards each other. And that's only one anecdote of many that I could share with you about the magnificence of our colleagues. I'd also like to thank members of the community whose generosity seems to know no bounds. I think none of us, well, I think we're all pleased but not surprised at the level of donations we saw in the early days of the COVID pandemic, but they have continued virtually unabated with meals and with masks and with PPE and with all sorts of very useful, much appreciated contributions. And as I've said on many occasions, but make no apologies for saying again, it would not have been possible for Chesterfield to respond in the magnificent way it has if it had not been in such close partnership with members of the community who have rallied around so amazingly. So thank you for that. And last but by no means least, we're very conscious of the NHS that we are not the only place that has frontline workers. The bus drivers who come to and from the hospital every day, train drivers, delivery men, and of course supermarkets keeping bread, butter and other essential supplies on our table has been very much part of the wider effort. So huge thank you to those two. And of course, talking about frontline, there's always a definition of frontline in the hospital, isn't there, about clinicians and people in clinical roles. But we had a very nice event last week to say goodbye to Lynn Andrews as Director of Nursing. And she reflected on her time in the trust, but also specifically during COVID. And in her thanks, I noted how many of her remarks of thanks went to people in non-frontline support roles. And one example of that, or two examples of that, has been our procurement function that has single-handedly done the battle to maintain our PPE stocks. We've never run out through the whole period, and in fact we've been in a position to share with others. And indeed our communications function, we've kind of kept that knowledge and understanding going around the trust, but also those are really important things for the community. So to each and every one of those people who've responded so magnificently, a huge thank you. And also, of course, our condolences to those who have lost relatives to COVID, or indeed those who have health conditions that are being complicated by access to services during COVID. We appreciate it's a difficult time, but our thoughts are with you, and we're redoubling our efforts to make sure we're doing everything we can for normal operations to resume in the hospital as soon as possible. So I think that's enough by way of introduction for me. I noticed also a comment in the comments from Krishna, who started with us as our new chief nurse on 5th of October. I think you're only with us on this call briefly today, Krishna, but it's very nice that you could join us and a nice opportunity to say hello. And we'll give you a full and proper welcome, of course, on the 5th of October. On that note, I'm going to pass, please, to Tony for the Chief Exec's briefing.
Okay, thank you, Helen. Good afternoon, everyone. I think the report reads pretty straightforward, but I draw your attention probably to 4 elements. Just an extension of the conversation and introduction that Helen's given around restore and recover. Pleased to say, still the case today that we have 0 COVID positive patients in the hospital, so that's brilliant. We are very much focused in our planning assumptions on the potential expectation of a second wave, so we're still keeping our COVID facilities available to us, but Haslam Ward is the only ward at the minute that is made available for COVID positive inpatients, but we have nobody on there of that nature at the minute. And in ITU, I think we have 1 patient who clinically is demonstrating symptoms, but not from a swabbing nature, so that's showing how things are calming down. But we're planning on the basis of what if there's a second wave. We're right in the middle of also starting to think about what about winter, and if winter comes back as normal, that will be challenging, and we're starting to see attendances coming through our ED front door that start to reflect the pre-COVID levels, so that's given us a different type of challenge. Many of our services were either stood down or diluted in terms of their activity levels. We're trying to restore those, and we're also trying to prepare as normal for winter things like flu and norovirus and all the sort of testing that we do for that. So there's a really fine balancing act. I'm aware people are always concerned about whether have we got elective surgery going on, etc. There is a national sort of risk stratification of all patients that we follow. So all urgent patients and all cancer patients, we are continuing to operate on those patients, whether it be here or whether it be at Barbara, the independent sector, which is a sort of national drive to use all available capacity. We're using those facilities to allow us to do procedures. I will say that we have a nervous population. They're nervous because they're worried, from a COVID point of view, if I come out of my isolated bubble to a hospital for a procedure, will that affect me? And that's affecting their decision not to take up their offer of surgery. You'll be aware, hopefully nationally, that many people are returning to work, but many of the isolation procedures for surgery require isolation 14 days before your procedure, and many people are again reluctant to take up their procedure because they're back at work earning money. So that's a challenge to the nation in terms of how we give the patient confidence to come back and have that procedure. But we are starting to, have been for a number of weeks, actively engage in our patient population to come back and get that treatment that they need. So that's all I was going to say on restore and recovery, but as I cover my other points, I'm very happy to come back and take any questions. I'd just like, again, from a staff point of view, fantastic effort. As Helen says, many volunteers in terms of the different support that we've given to our patients, but likewise in support to them. Over 3,700 have had the antibody test for COVID, which I know in there says, it's about 16% positive in terms of have had it. We're pretty much exhausting in the sense of we haven't got many more staff who want to have that test to be done, but that's a really good position, and we offer the test to the wider community as well. The other point I'd like to make mention of is the refresh of the trust strategy. There's been a number of workshops that have been had over the last couple of months, started to develop that thinking. And I know the board had a session on the 24th of June, I think it was, where we started to debate how we might shape that. It's just to let governors know that the product of that work is going back to board next week. And in the coming weeks and months, governors will start to get engaged in that strategy being developed. And then I'd probably want to just introduce Zoe, if you wouldn't mind, Zoe. There's reference in there to staff conversations, just to check in with all of our staff, particularly our vulnerable staff, as to how they are feeling at the minute, you know, during COVID and post-COVID. And we're having that conversation as the whole of the NHS is with all staff, but I didn't know whether you wanted to elaborate on that, Zoe.
Yeah, I can come in there. I'll try with the camera on and see if I keep my connection. Thank you, Tony. So we've talked at the governors before around the support conversations we've been having initially with people who were seen as being in more at-risk groups, and that's certainly where the conversations were prioritised. We've since then moved on to say that everybody needs to have one of these support conversations, so we can have the discussion with every member of our workforce around how they're feeling and what we can do to support them at this time. We keep making sure that these are happening in terms of the workforce group and also briefing through the tactical group several times a week. And we've also put more support on for managers to help with the conversations. So if people have been asked questions and they're not quite sure where to go with that, a number of members of the central workforce and OD team drop-in team sessions, so this kind of thing where people can join a call and, you know, seek some support from people to build on what we've already had in place so far.
Thank you. And Helen, I would draw a close at that point and take any questions on any points of the paper.
Thank you very much, Tony. Can I just check who would like to come in? Perhaps you'd be kind enough to indicate in the chat if you want to come in. It looks like that has been a very comprehensive update, Tony and Zoe. Thank you. Okay. I think colleagues will be grateful for that. There were a few items raised in the pre-meeting that we might return to, not unrelated to your report, but we'll have a discussion then too. Okay. I'm pleased to advise that in respect of the next item, which is for which KPMG are going to join us to review the year and the external audit that they have undertaken. And it's a pleasure to welcome back Katie Scott and also Andrew Cardoza. I would like to flag that, of course, Andy Bostock, who has come to our meetings for the past 7 years, has moved on, still within KPMG, but focusing now on consulting and internal audit. I wrote to Andy on behalf of the Council of Governors to extend our thanks. It's a tricky role being an external governor, and as I said to Andy, he was both challenging and solution focused in equal measure. So I have conveyed our thanks to Andy for all his hard and excellent work. So a warm welcome to Katie and to Andrew, and I think I'll pass the baton to you now to take us through your slides.
Thank you very much.
Yes, thank you. Andy, do you want to just say some words first?
Yeah, so thank you, Chair. Thank you for the warm welcome. So yeah, my name's Andrew Cardoza. I'm a director at KPMG. I've been at KPMG for well over 25 years now. I sit for accountant, worked across the NHS for many years as well as an external auditor. In the same vein as Andy Bostock, who's my boss for years, we work to be pragmatic, we work to be challenging, but we always look to be fair. And I intend to carry on that, and especially with the continuity that Katie brings, I hope we can maintain that going forward. With that, I'm going to hand back to Katie to take us through our presentation.
Yeah, indeed. So the first of our slides effectively is setting out the team. So of course this was Andy Bostock, who's the outgoing partner, Andy Cardoza, who's coming in to be our new engagement lead. We'll sort of say keeping the name the same made it a bit easier for everybody as well, we thought. So I am the continuity, and I've been on the audit for a number of years now as well. So in terms of the past year's audit, so we finalised the 1920 audit at the back end of June. So we had, as the audit planning went on back in November. We then come out on site, and we were able to be on site back in February to do our interim work, where we look at some of the controls that the trust has in place. Then in May, obviously due to the COVID situation, we weren't able to come on site, but we worked with the finance team remotely, and it went smoothly to then sign off at the end of June. The key change for us from a COVID impact was more around, we were not asked to do any form of the quality assurance work. So the quality report, previously we would have presented to you on the indicators that we looked at, whereas this year we didn't look at the quality report at all. And one of the initial key changes that would have been for this year was on IFRS 16, which is where you take the operating leases that would normally just go through an income statement and they're brought onto balance sheets. Again, coronavirus delayed all that, so that's now next year's work, which I think was a slight relief for everybody involved. We didn't have to do all of that on top of the other pressures that they were all under. So going through into financial statements, so this summarises what we do. So we ensure that the financial statements give a true and fair view of the financial affairs at the trust, and that they've been prepared in accordance with the standards. So we ensure we look at the financial statements, and we look at the remuneration report and agree those as supporting evidence, and look at where there are areas and various judgmental areas where the accounts could be manipulated in some way. One of the key areas of judgment that we refer to is around the valuation of the land and buildings. So land and buildings are valued by an external valuer. So we have conversations with the valuers to ensure that there are no strange assumptions made or anything like that. So then going into page 5 of our report, we note that we've made 5 recommendations. I haven't flagged in there in terms of what they were, because they're all kind of medium level recommendations, just sort of internal controls points, and nothing significant that worth noting rather, but they did go to Audit and Risk Committee on the 19th of June when the accounts were approved. Section 2 details the impact of COVID on our report. So as I touched on earlier with the quality report, so we weren't required to provide the assurance over the quality report this year. There were some minor introductions around on the COVID requirements for the annual report. IFRS 16 touched on already. We had to look at the value for money. So we look at value for money arrangements. So does the trust have appropriate arrangements in place to provide value for money within the services? We look at whether coronavirus would have had any impact on that. We didn't even there be any new significant risk as such, but it was definitely something that we had part of our risk assessment. We then look at whether there would be any events after the reporting period, so anything post the 31st of March that should be included within the financial statements. We determined no. And then within the valuation, so as at the 31st of March, the land and buildings, as I said, were valued. However, this year, all external valuers introduced a material uncertainty clause within their value report, and it wasn't to invalidate any of the valuations at all. So there was no significant implication on the audit. It was just something we had to bear in mind going through. Then we also looked at around the financial statements going concern point. So has the trust got the ability to continue for the next 12 months? So I've fortunately been a trust part of the NHS network. We deemed that there was. Inventory, we weren't able to attend to stock counts at year end, so we did additional procedures there with finance to ensure that the stock balance isn't misstated. Where we do our agreements of balances exercise, so we would normally look at there's a large trust exercise that's performed, and we would ensure that the threshold, we would look at everything above 300k crossed previously. We still unfortunately have to stick to that lower threshold. So it was the challenges there in terms of the trust was looking at different threshold, but again, there was nothing significant to note. There were a few differences, but nothing major. And again, they were reported within our ISA 260. And the financial statements, just in terms of procedures, normally the deadline for the accounts is the end of May. This year it was the end of June. So unfortunately, the trust had 4 weeks to prepare the accounts. We normally have 4 weeks to audit it, but this year we had 8. So we had the lucky side of having slightly longer to audit it, which I think relieves a little bit of pressure off the finance team as well. So then in terms of our use of resources, so we talk about the value for money arrangements. we had 2 value for money significant risks. So we referred to those. One was around financial sustainability, i.e. does the trust have enough cash, and are they meeting their control total? And we also looked at the subsidiary that was formed last year. So as I'm sure we're aware, last year the subsidiary was set up, and it went live from the 1st of April. So we then looked at the governance arrangements throughout the year, reviewing board minutes, just to ensure that there was appropriate segregation of duties and that things were being monitored appropriately. So that's everything we've done this year. And I said normally we would have a section here on our quality report, but this year there wasn't anything. So happy to take any questions should there be any.
Thank you very much, Katie. So we've got Mike Killick who'd like to come in, please. Mike, as you'll be aware, is the chair of the Audit and Risk Committee. So pleased to hear from you on this, Mike.
Yeah, good afternoon, everybody. It's not really a question, it's a couple of statements of thanks, really. Certainly, I pinged a personal note to Andy to thank him for his time. Other Andy, you're very welcome. We haven't met yet, but we'll have a proper opportunity to shake out, well, pump fist or whatever it is we can do in this environment.
Touch elbows.
Yeah, exactly. Katie, thank you for all your hard work and your continuity. And I also I hope Lee's on the line, and we've done this a couple of times, but I just wanted to do it for the governor audience, which was to thank the finance community in the hospital, who have worked incredibly hard under difficult circumstances to get what was essentially another very, very clean audit. We've never had problems with the external auditors raising challenging queries. They do a thoroughly detailed job. They dangle us upside down and make sure there's no loose change in our pockets, which is great. And we always come out smelling of roses, and that's certainly due to the hard work in the finance team. So I just wanted to put that on record. And that's it. Thanks, Helen.
Thank you very much, Mike. And I'm sure all of us on the board and on the Council of Governors would echo those thoughts. It wasn't the best circumstances in which to be concluding an audit, and clearly you've done very well. Can I just check? David Lyon, I think, wanted to come in with a question. David, can we go to you, hoping that your brass band has quietened down?
Try it. I hope it's better this time, Helen. It is.
Very good. You're clear,
right.
Loud clear.
I'd like to ask a question relating to external audit in a vague kind of way. I wonder if you could pass to I wonder if the presenter could cast her mind back a few years ago to a situation where external auditors PricewaterhouseCoopers were involved in a situation after 32 years service were dismissed by Tesco. I'm afraid I always ask this question of external auditors. And it was a matter of about 263 million accounting fiasco. Now, as far as I can foresee, we have protection here, but I would like the presenter or someone in the finance department to assure us that they have full protection here and such a thing could not happen. My question.
Yeah, I'm happy to pick this up initially, Katie, and then if you want to pick it up as well, it's fine. And or if anyone from the finance team. I mean, the PwC thing and the Tesco fiasco, which we can call it that, I'm sure it is the case that it was a failure of audit. One of the things that's happened as a result of that is that we do have to do a lot more work as external auditors now on fraudulent revenue recognition, because that's what that was coming from in terms of income being counted before it had actually been received. We have to look at that across all trusts and all FTs and CCGs across the country that we audit, making sure that the accounts are manipulated to make sure that the income that you record is actually the income that you've had. And we do that in a number of ways, but that is absolutely covered, David.
Yeah. There's also a huge amount of regulation in this area now on the back of the Kingman and other reports, David. In fact, I had a meeting with the Simon Dingemans, who of course is now the outgoing chair, a couple of weeks ago, and you know, I think there's a whole approach being put into this that should mitigate the worst of those risks into the future now. So Lee has offered to come in, but
Thank you very much, Helen.
Yeah, thank you, David. Thank you. Was there something you particularly wanted to add, Lee?
I want to be mute.
It's probably quicker to say it, Helen, than to type it, so I'll say something. One of the reasons why the outgoing Andy is outgoing is not to allow to an incestuous relationship between the finance team and external audit, is why we've got a new Andy. And by and large in the NHS, we tend to swap in and out our external audit firm to ensure that sometimes finance, which can be a little bit of a strange thing in most sectors, not least in the NHS, is being given a fresh set of eyes. So hopefully that gives the right assurance to the governing body about quite how the relationships between the external audit and the finance team works. Thank you. Sorry.
No, very helpful and a practical manifestation of some of the mitigations we've been talking about. So thank you, Lee. Denise, please.
It's really just on Lee's point. When we actually appointed the external auditors, we knew that Andy would be leaving. We were obviously told then, because of the length of time Andy had been at the Royal, we knew that he would be leaving. So just to say welcome, Andy, Mark 2 or Mark 1.
Yeah, thank you, Denise. And of course, that would have played a factor in our considerations about the options in front of us. So very helpful to bring that up. I think the fact that you've had a lot of thanks and appreciation and applause for what it is you've done is a testament to Mike's vote of thanks on behalf of the Audit and Risk Committee and Lee's on behalf of our finance professionals. And just to reiterate the same on behalf of the Council of Governors and the Board of Directors, we look forward to continuing our relationship with you and enjoying your usual high standards. So very well done and a big thank you. So that brings us, if we may please, to item 6. I am minded to declare a short comfort break, but I think we'll do item 6 first, and then I will release you onto your capsules very briefly. If you've got anybody to put it on, you could ask them to put it on now. So item 6 are the governor measures of success. The context for this is this has been a very good advance in governance, in my view, about it being predictable where the governors were most likely to want to focus their scrutiny and their observations. And of course, getting alignment. You know, the Board of Governors are necessarily and sensibly very responsive to what it is that's front of the governor's mind. So we wanted to make sure that not only that was predictable, but that if there were any gaps between what was close and important to the Council of Governors and to the Board of Directors, not least of all in focusing on the business plan for the coming 3 years, that those gaps were explored and understood, so that we got closer to having a shared set of measures that were really going to be the bellwethers of whether or not the trust is doing what it needs to do. And we settled on 6 through a quite involved and lengthy and discursive process, which I thought had a great value a couple of years ago now. And the time has come for us to refresh that. And of course, it's been a bit difficult refreshing it virtually, but we've gone through a process where the Nominations Committee have looked at it. It's been referred to the Membership and Engagement Committee, and indeed board members have had an opportunity to comment. And sorry, I should not say board members, I should say Council of Governors have had an opportunity to comment, and the comments that have come back have been appended to this report. I don't want to put words in anybody's mouth, and I'm going to ask both Denise and Margaret to come in. But I think I'd summarise the top line as being, well, you know, the issues we settled on previously were by definition strategic. And if you've got a strategic set of priorities, by definition, you don't keep changing them every year. So consequently, there is a desire with the addition of, with one possible addition, that we stick with the same set of priorities because we think we landed on the right strategic priorities. And given that a number of them are only partially seen through, that we stick with them until we deliver. And that decision, of course, is without prejudice to any changes you might want to make on the back of the trust strategy being refreshed. But I think, as I said to colleagues in the context of the nominations committee, whatever the refreshed trust strategy says, I will be really surprised if the 6 things that governors set out as being of key importance in any way, shape or form disappear. But of course, that opportunity for you to reconsider at that point will, of course, be made available. So that's kind of what's in front of you. There isn't a report against those priorities at this meeting, because it's at this meeting that we kind of do the review of the priorities, right? But assuming we can settle on those priorities today, the report to the next Council of Governors will be the usual progress report with the responsible non-executive director giving the report against that particular item. And of course, I think that's the other thing. I mean, I know I'm stating the obvious and what have you, but I still think it merits saying that, you know, the governance dynamic we have going in the Council of Governors, where the governors are very visibly and ably holding non-executives to account rather than the executives to account, is hugely aided by us having this discipline and structure in place. So I think that has been working well for us, and hopefully will continue to work well as we refresh the document. So can I come to you first, Denise, please?
I just wanted to add, because we agreed, didn't we, that we were going to have an extra one for restoration and recovery?
Yeah, we did.
Because I think that's really important, given some of the conversations we had today about elective surgery and everything. So that was just what I wanted to add. That obviously, there was another one on restoration and recovery, wasn't there?
Yes, it was indeed. Yeah, it was indeed. So we will make sure that that goes in. And we've got Tony on the call, whose team ultimately pulls all this stuff together, along with Gillian, of course. So we'll make sure that goes in. Margaret.
Yes, thank you. And at the Involvement Engagement Committee, we obviously supported the idea of keeping with the existing things. The comment that I've made as a personal comment is, which you can see on the paper, is about the urgent care village, as it's still referred to on there, but the ED department. I do think from the members of the public's perspective, if we are going to, you know, we have now got the funds to go ahead with that, we should be actually monitoring the progress and keeping people to account on how that's progressing. I think it would be something that would be very important to our colleagues, and it's already been said about winter pressures and ED numbers coming up again, and we all know how non-fit for purpose our ED department is. So that was the reason for me actually asking whether we could actually include that, but I don't know what everybody else thinks. But from the committee, we supported the idea of carrying on with the 6 that we've got, plus the extra one Denise has just mentioned.
Yes, yeah. And of course, your own personal comment also needing to be incorporated around estates. Margaret, I thought that was very helpful. Yeah.
Helen, could I come in at this point? If it would help, under the restore and recover, I could make reference to the urgent care village, because it kind of fits really well. And we'll be taking stock of our original designs versus all the things we've learned during the COVID period and how we move things forward, and then how we might go about the build process, etc. So I think it would fit quite well under restore and recovery.
Very good, very good. Thank you. I think that's an elegant solution. Yeah.
Okay.
Thanks for that. Can I come to John Bolt, please, who wants to come in?
Thank you, Helen. Yes, it was a question about urgent care village, and I think that's been addressed. So, yeah.
Very good. Thank you, John. In which case, to summarise, we've settled on good strategic priorities. We're going to continue on with them, with one addition around restoration and recovery, within which we will be mindful of the urgent care village and any other changes that are required to the estate on the back of the COVID response. And we anticipate that they will endure beyond the strategy refresh. But should the strategy refresh give us any pause for thought, we will build in an opportunity for governors to have a further review. Very good. Now, I'm going to suggest that we all have a short comfort break. I know tea time has definitely arrived for me. So it's now just after just coming up to 1:15. Could I suggest that, given the fact that it takes a bit longer to get a cup of tea than just go and press a beautifully pre-supplied flask that we would have should we all be together, that we give ourselves the luxury of coming back, please, at 2:30, if that's all right, and we will do the COVID-19 finance and operational planning update then. Well, if I can say a warm welcome back to everyone. I don't know about you, but that was a very welcome cup of tea from my perspective. I managed to squeeze in two. And we'll go without further ado, if we may, to the item 7, the COVID-19 financial and operational planning update, please, Lee.
Thanks, Helen. Normally at this time of year, we'd be updating the governors on what we submitted in the annual planning documentation to monitor stroke NHSI, but obviously the world kind of got slightly flipped on its head, did it not, in terms of COVID towards the end of March. So all of that sort of annual planning cycle was kind of set aside. So it's been a somewhat odd time financially as well as operationally in the trust about a very different way of working, and the reason why we've not got an operational plan to discuss and bring to the governing body is all of that process in the English NHS nationally was put on hold. So this paper just describes what were the external auditors actually auditing in terms of where we got to at year end, which was, after a bit of chicanery about technical items of impairment, was broadly break even, which is broadly where we said we'd get to in the regulatory space. It notes that under the funding regime that was put in place for COVID, we are breaking even. And the reason why we're breaking even is all NHS organisations are supposed to break even because we've got a different way of funding NHS organisations through the COVID period. And then the third section of the report just explains what the current financial and operational arrangements are. And this COVID funding regime was put in place for what was anticipated to be the first 4 months of the financial year. I've now had confirmed it's going to be for at least the first 5 months of the financial year that will get us to the end of August. And I anticipate it's highly likely to be for the first half of the financial year. And it just explains in section 3 of the report, why was this put in place at a time of crisis, what was actually put in place and what's likely to happen next. And what we're highly likely to be left with is some sort of block funding arrangement for the organisation, which has both opportunities and risks in it, but none of that is yet confirmed. And if you were eagle-eyed and an observer reader about 3 weeks ago, you may have noticed there was an article there, but you may not have done, that described the fact that there's currently quite an interesting conversation taking place between the Department of Health and NHS E&I and the Treasury about what funding is going to be available for the NHS for the second half of the financial year, which hasn't yet been resolved. So how much we're going to be able to restore services whilst also potentially dealing with COVID isn't resolved at a national level, which is why we don't quite know what the funding is going to look like, either from a Derbyshire perspective or a Chesterfield Royal perspective for the rest of the financial year. So the report notes the year-end financial position, notes we're breaking even in month 2, and notes we're in this very different funding environment. at least for the first half of the financial year, in my view, and we don't quite know what's going to replace it yet because the national funding formula hasn't been agreed, and therefore we don't quite know how to interpret it locally. And I'll pause there because people have doubtless suffered enough.
Yeah, thank you very much, Lee. That's been very helpful. Can I just see if anybody would like to come in on that, please? Can I go straight to Judy?
Sorry, yes, here I am. I just sent a message. Welcome, Lee. I haven't seen you for a few months. Can I just ask how the proposed pay rises will come into this? Is this for next year, or could this make us financially insolvent?
The midnight announcement of 2 days ago, we're still not quite sure how to interpret, Judith, to be honest. So we were anticipating an NHS pay rise on average of 2.1% across all staff groups. Self-evidently now, if there's some late-breaking news about the doctors or other staff groups, which takes the overall pay burden higher than 2.1%, it may create a problem, but nobody in the service knows quite how to interpret the thing that was published in the dead of night 48 hours ago, Judith, if that's what you're referring to.
Yes.
We haven't received any formal notification of a deviation from what we were anticipating yet through the normal pay award bodies. So I'm certainly, for one, not quite sure what's going on, but Zoe may have more intelligence than me, which, to be honest, wouldn't be hard at the moment.
Thank you.
Thank you, Judy. Is there anything you want to add, Zoe?
Oh, I think we're waiting more information. I think that's fair to say.
Denise, please.
It was just really to ask Lee about the block funding, because having worked in the NHS for a long time and worked block funding, particularly in medicine, it was always an issue regarding that we were always underfunded.
It depends on how positive I'm feeling, Denise, about what I think about block funding. If we're given a span of control to work very differently with primary care and social care, and really trying to tackle where probably the waste is left in the health and care system on the boundaries between social care, primary care and elsewhere, block funding might work. If we're left without the levers of control to try and change the way how North East Derbyshire and Chesterfield work, and we're just left with a block amount of funding for the hospital, that does fill me full of slight dread, because the blended tariff funding formula we had last year that was meant to make us reach out and do things differently elsewhere, unless we've got the levers to do that, all that it did is made delivering our financial performance exceptionally hard with a low marginal cost rate for treating more patients than we anticipated to. So if the block funding's linked to some structural reform, I'm less nervous. If it's just that's all the hospital's getting, I'm less perky.
Yeah, I would agree. That's why I asked the question, because having experienced it, particularly in medicine.
Yeah, no, understood, absolutely, Denise. Unless we can really galvanise into action across the health and care system, it's just going to leave us potentially in a bit of a pig in a poke place, in my view, without enough money to deal with the number of patients we're likely to see.
Yeah, I would agree, Lee. Yeah, thank you.
Thank you for that update, Lee. That's been very helpful, and obviously it's going to be important, as you always do, to kind of come back to council regularly, because it's going to be an evolving picture, isn't it? So keep us in the loop. Very good. So that brings us on to the issues that were raised in the Governor's pre-meeting. So whilst it took us a couple of minutes to buckle down to work, with the kind of, context of us all being in different places, once we got going, goodness, we were on something of a roll. And there's been an awful lot of issues raised. I'm going to attempt to summarise them, and once I have, because I think it's important they're all captured in the note, but I think once I have, we will, in our usual fashion now, come back with response to each and every one of them, appended to the minutes of the Council of Governors. But I think there's one or two, particularly around clinical issues, where we might want to pause and have a bit of a conversation in the meeting. Before I do that, I know we've got Sarah on the line. Sarah joins us as the acting chief nurse. So welcome, Sarah, and this is by way of heads up that you might be on any moment soon. And I'm not sure if we've got Hal on the line. Do we have Hal on the line?
Yeah, I'm here, Helen.
Great.
Yeah.
Well, I think you will be up in a minute too, Hal.
Yeah,
so
that's
brace
right.
yourself.
I've just not got the video on because it messes
That's
up the
fine.
connection.
Yeah, no worries. Just be on notice. So in terms of the list of issues in the order in which they arose, we talked about visiting, and I was able to explain that visiting is being reviewed weekly about when will be the right time to recommence. And I also explained that we were reminded to tie to visiting for members of the public and relatives of patients, that with when NEDs and governors routinely start going back into the trust, or maybe not even routinely, but that being a kind of, one of the gateway requirements, and the need for us to think about that in the round. So colleagues are now familiar with what's happening there. We spoke about Crow Lane and the concerns about the road closure from local residents, and how we balance that with the desires of people for easy access and egress from the hospital where they're cycling. And Kate Caulfield very helpfully explained to us some of the liaison she's been doing with the local authority. And we know that both Sarah Turner-Saint and Dennis Kentrop have a number of actions in place to move that forward should there be any move towards a permanent closure, which as a trust we have committed to not progressing in the absence of full consultation, obviously in collaboration with the local authority. So I think we have reassured residents about our intentions and the processes that would be involved, so that there wouldn't be any unexpected detriment in that regard. Then we had a number of conversations about what you could loosely call restoration and recovery. It's been very helpful to have Tony's update on the Chief Exec's report, but some of the specifics that came on the back of that were, when are electives going to restart? And I was able to explain about the huge amount of work that Tony, Marie and others are doing to get the balance between keeping capacity, keeping flow going with all the extra requirements of distance and infection control, and then keeping a balance between what it is we as a trust think might be the best outcome in that regard and the requirements of our regional and national colleagues. But I did undertake that we would give further insight to that in the meeting. So I think if colleagues wouldn't mind picking that up. And in the same breath as that, and to illustrate that, we heard about a friend of a governor who was due to have prostate surgery at the start of COVID, hadn't had it because of COVID. The cancer has now metastasized, and there is real concerns about his survival. And we talked about the statistic you shared with us, Hannah, board, about the very low levels of predicted survival, where you're having even relatively simple surgery, but should you contract COVID and need to deal with that kind of post-operatively, and the very fine judgments that were having to be made. And we expressed our wish as governors that patients and families are being properly brought into those very fine judgments and decisions. So some further insights around that, I think, would also be very welcome in the meeting. The issue was raised about isolation hospitals in the days of TB and polio, and not least of all in the context of the proposal that Hallam might become the site for COVID patients, albeit within the limitations of the donating hospital, so to speak, having to send 2 nurses, and the fact that consequently that may not be a workable solution for it. But some thoughts about how life might be in terms of hot and cold treatment facilities in the restoration and recovery phase would be very welcome. And then we had a couple of items around long-term effects. What are they likely to be? Where's the science up to on that? And specific examples given around steroids, and I think we should add to that also sepsis and the very close alignment between sepsis and COVID, and whether or not we've actually understand what really good practice looks like in that regard and the extent to which we're able to deploy it and trust. Related to that, a real concern that GPs are not being advised when a patient of theirs tests positive for COVID. So consequently, unless the patient informs the GP can't really treat that patient with a kind of holistic understanding of their medical history, which strikes me as quite alarming. I did share the plans through Joined Up Care Derbyshire for us to once again pursue a truly integrated patient record, which would be a great advance. But I imagine we might need to be thinking about what are the risks and opportunities that might need to come in advance of that bigger solution being in place. And again, some comments on that in the meeting will be welcome. And last but by no means least, and probably not for further discussion of the meeting, John raised on behalf of Derbyshire County Council some of the concerns about care homes, and in particular the availability of GPs and the interface between primary care and care homes, which Ruth was kindly able to throw some light on in terms of how things are working in and around Chesterfield. So if I don't know who wants to lead the charge, whether Tony wants to lead the charge and how it is we're planning around some of the detail of that, getting electives back up and running. And Hal and Sarah, if you want to come in on some of those issues about our real understanding of the disease and what the long-term effects might be and what the best practice in treatment may be, and indeed how it is we as providers join up to give patients the best possible all-round care. So maybe while I give Hal and Sarah a moment to think about those, I might come to you in the first instance, Tony, to just talk about the kind of the detail of the planning for the restoration of electives in a little bit more detail than we did earlier.
Yeah, okay. Well, just before I get to electives then, so in terms of our COVID or red pathways and our green non-COVID pathways, hopefully governors are aware that we have really well-defined escalation plans. So if you were coming, you'll know that we flipped ED round from to a red and a green, and we made use of the fracture clinic at the height of COVID from the red phase, and then we flipped it back in more recent weeks when things have eased off. So we have clear plans as to how we will escalate if the need be coming through the front door. Likewise, if our numbers of admittances were to go up and we started to suspect COVID, and it's of a respiratory nature, that's why we used Markham as the first escalation ward for suspect COVID. And we start off that pathway really very clearly, isolated into a side room, if all side rooms are filled, into a cohorted bay, and then if Markham did get full, at its height it did, we overflow into Pearson, and we use Pearson in exactly the same way, side rooms, bays, etc. So the escalation, if it was to come back for a COVID wave, we know exactly how we will scale up. Likewise, in our ITU facilities, we know exactly how we will phase the escalation up. And so we know ultimately we've probably got a capability, because normally we have about 6 beds, a capability of stretching all the way to 28. But that is a stretch with the resources. And you made reference to that earlier, Helen, with all the volunteers that we had in terms of resourcing that with the rosters, which was fantastic. So we know exactly how we would scale up. What we're currently working through now is, you'll also be familiar, hopefully, our normal winter planning, we're usually in that same spirit. We know exactly how we would scale up and expand our wards. And we usually know the exact order that we will do them, and that's no different to how we're planning now. So I'm confident that from a COVID point of view and from a non-COVID point of view, we know how to escalate up and marry the two up. What I will say to governors, from a planning assumption, if the planning assumption which we are being asked to consider is, what if you had a wave 2 at least equivalent to wave 1? What if you had a normal winter? And what if you restored all your services? Do you have the facilities? And as of today, right now, I'd be about 3 wards short. And so the debate in the operational teams is, how might I facilitate the creation of 3 wards? And that might mean I use Ashgate, which would only give me half a dozen beds. I might use community. I might scale down some of the elective. I'm doing that as a bit of a segue into there, as we normally would in terms of cohorting patients, or I might use the independent sector. So I have it there. That's the melting pot at the minute. If I believe the modelling, then I haven't quite got enough capacity. But that's where we were at the start, and we worked all those things out. From an elective position point of view, all of our patients will have been contacted, be it patient, cancer or our elective work, for a discussion of where they're at, and then tactics identified or care plan agreed with that patient as to how to handle things. We use nationally agreed profiles in terms of the risk stratification. And I think I alluded to earlier, we are trying to reinstate our elective work. It won't quite be at the scale of 100% pre-COVID, but we are actively trying to bring our services on board. Some of our not necessarily elective work, but some of our orthopaedic work, etc., is being done at Balba because it's a cleaner site to ours, or can be the simpler provision of procedures can be done over there. But as I alluded to earlier, we have got a big, forgive my frame of words, but a charm offensive with our population to say it is okay, it is safe here. We do the right things from an infection control point of view. And I would reference the antibody results is a testament to the social distancing and the infection control procedures of this hospital, that looking back, only 16% of our hospital population has had once upon a time COVID. So it's a good testament. So there's an enormous amount of work, and likewise, we're in very good conversations with our primary care colleagues, not just Royal Primary Care, but primary care colleagues, in terms of how we're handling the interface as to when a patient gets referred, how we handle their referral. Do we look for mitigation being handled within the community via primary care, or do we, as for the majority, we hold on by far 99% of the referrals we hold on to make plans for the future. So I'll do that as a bit of an introduction, Helen. I don't know if it quite hits the spot, and there was a breakup in your narrative that I might have missed something, but if I have, please ask me, and that may be a segue to Hal.
Excellent. Thank you very much, Tony. And let's go straight to Hal, if we may, please.
Thank you, Helen, and thank you, Tony. I'd reiterate and agree with lots of what Tony said. I'll try and cover all the points that I think you raised, Helen, but please do tell me if I've missed something, because there were quite a lot of things in sequence. Picking up, first of all, from Tony's point about we've got a charm offensive to do from the point of view of the population, and reassuring them that they feel safe coming into the hospital. The background to that is Helen mentioned briefly, but there's been quite a lot of research published suggesting that for patients having abdominal surgery, so this is both elective and emergency abdominal surgery, that the mortality was up to 25% in people who either had coronavirus at the point that they had their surgery or developed it subsequently. And that's the background of why, at least from the point of view of restarting surgery, there was understandable anxiety both for patients and for the surgeons themselves. We sadly had a couple of deaths early on from patients who we're not sure either caught just before or caught just after having abdominal surgery and did die. And so our surgeons in our hospital are very aware of this as a risk. And as a result, from the very beginning, they've absolutely been counselling individual patients about that risk. So it's in answer to one of the questions, I think, it is something that is being discussed with patients. The risks seem to be specific to abdominal and thoracic surgery. We don't do thoracic surgery within Chesterfield. That's all done in Sheffield. Thoracic and cardiothoracic surgery. The risks do seem to be significantly less for procedures such as, for example, if you had your knee replaced, the risks are much less, and it's something to do with the kind of added physiological stresses that abdominal or cardiothoracic surgery put on your vital organs and have a knock-on effect on your lungs, which is obviously the way that most patients with coronavirus have sadly died. So we're very aware of that. We are counselling patients about that. But the most important thing is that we don't have lots of coronavirus in the hospital. There's lots of work going on regarding, for example, for elective surgery, patients being absolutely socially isolated for 2 weeks prior to their surgery, us swabbing the patients beforehand to make sure that they're clear, us having a COVID-free site at the moment. None of that works quite so well if you need emergency surgery, but the fact that the site is currently free of coronavirus obviously makes it much less likely that they may catch coronavirus while here. So it's to sort of reassure people that we are doing as much as we possibly can in order to make things as safe as possible. There was a question about a specific sad case with a gentleman with prostate cancer whose disease had become metastatic because of the delay with the surgery. Obviously, I don't know the individual case details, and I'm very sorry for the individual if they have come to harm from this. But I think what I've just talked about may help to understand why surgery was delayed in these cases, that we kept doing surgery where we possibly could and where it was an emergency situation. But in some cases, it wasn't the right thing to go ahead with surgery. A little while ago, to give some context about the fact that coronavirus will cause morbidity and mortality in people who don't get coronavirus. There was a study published by Macmillan and Cancer Research UK, which suggested that a 3-month pause in activity would result in an extra 10,000 deaths in the population because of delays in giving that cancer care. And you can understand how on an individual basis it will be terribly difficult to work out whether and at what point their disease metastasized to elsewhere. But if you look at a population, then you can start to make some reasonably based scientific judgments about how the population will be affected by this. And that I haven't got a solution for that, but it is just a reality of when those decisions were being made about trying to stop the exponential rise in coronavirus cases. We knew that there would be some downsides. On a more immediate basis, we know that patients didn't come to hospital when they had chest pain and they were having a heart attack or when they were having a stroke. We know these things happened. It wasn't anything that we desired, but it was a sad consequence of the whole situation. I'd add, just as a final thing, for that individual case, fortunately, prostate metastatic disease very often does respond very well to hormonal treatments, and many patients with metastatic prostate cancer live for many years because of the responsive nature of their cancer. So just on an individual basis, I hope and wish that this patient is one of those fairly large numbers of patients who do respond very well to non-surgical treatments for prostate cancer. I think there was then a question about what we were doing to support people after coronavirus. Just this week, I've been involved in discussions about, we've developed a leaflet from the point of view of life after coronavirus, which we're giving to our patients. That covers a range of, and that's been done in consultation, I should say, with Derbyshire and in fact some partners in Staffordshire. People may know that Burton Hospital, which is part of the Derby Hospital group, is in Staffordshire, and so we have some links with them as well. And it's often useful to use other people's good ideas. So we've been doing that and sharing good practice. So we've developed that, lots of it around the psychological aspects of coronavirus and recovering from that basis, some of it around the general physical debility. And then there's some specific things regarding, for example, respiratory care. There's some early thoughts that some patients who have coronavirus may develop long-term lung fibrosis, for example. It's unsure. We don't know it's a new virus. We don't know, but it's a concern. And so we're organising as a routine respiratory follow-up for those patients who've come into the hospital and had lung disease related to coronavirus. So that's already been thought of and is being, those patients are getting that follow-up. I think there was a question regarding communication to GPs about patients who have coronavirus. I'm not quite sure what that referred to. I think without exception, a patient who had been in hospital with coronavirus the GP would be informed in the discharge letter about.
Can I clarify how? Can I clarify? Apologies if I wasn't clear. What I meant was the national testing scheme. So not necessarily the hospital. It's sort of a wider issue. We certainly are informed if a patient has tested positive within the hospital. It mentions it in the discharge letter, which is very helpful. But patients in the community who are having testing through other mechanisms, who are testing positive and then isolating nationally, we're not being told as GPs that they've tested positive. So we know about the patients who've been into hospital, which one might look at as the tip of the iceberg. And we have an unknown number of patients testing positive through the national scheme, of which we're totally unaware.
I understand, Ruth. I'll probably ask Tony to come back on that one in a moment, just because he's been much more involved in the kind of national testing. But the final thing, and maybe Helen will be able to clarify me, there was a question about steroids, but I didn't quite catch what it was about.
Mark Koppel has raised this. I don't still have the bit on the chat. I wonder, Mark, would you like to come in and frame your question directly to Hal, please?
I'm trying. Can you hear me? Okay.
Yeah.
I just wanted to know, given that we know that now nationally there was the announcement that this new treatment worked or had some benefits. I know yesterday there was another possible trial that might in the future work. Nebulizer, wasn't it? Just how the hospital responds and how you kind of feed that into treatments as new patients if we get more new patients.
Okay, so I understand, so I can answer that. So the first thing to say is that the hospital has been absolutely fantastic from the point of view of involvement within research. The specific trial regarding dexamethasone, which is the steroid treatment for people who were either ventilated or requiring oxygen, the trial showed quite a big benefit from them, was called the recovery trial. Chesterfield, I don't know the exact latest figures, but until recently we'd recruited the 4th most people in the country into that trial, which is, I think, an absolute credit to our research team, given that we're a relatively small hospital. Part of us being really involved in research has included things like the plasma trial. We were the first people in the country to give plasma to anyone with coronavirus. So again, real credit to our research team for being involved. As a result of that, we're absolutely aware of, as well as everyone else, about the dexamethasone trial. And as soon as that early report was published, we changed all of our pathways internally to ensure that people who already were in hospital and anyone who came in subsequently who met the criteria, so that's the people on oxygen and on a ventilator, were given dexamethasone as part of their standard treatment. We likewise did it for the antiviral drug, which I'm going to pronounce wrong, but it's something like remdesivir, but we did that again, that our patients were getting that. So I can completely assure you that our patients are getting the latest up-to-date treatment, as well as actually being really involved in all of that research that's been done nationally, and a real credit to our research team. So I'll name drop them a bit because I know they've done some fantastic work.
Just before we let you pause for breath, Hal, the last one was one from me around sepsis. I read a press release this morning about the development of a test that would help predict the onset of sepsis up to 3 days before the symptoms. And the suggestion was that this would be particularly helpful in the context of COVID patients. So is sepsis taking even greater prominence in the context of COVID?
We, funny enough, had a discussion at the Clinical Effectiveness and Safety Group just yesterday about sepsis, and obviously all the work that the governors will be well aware of to do with, getting antibiotics to people within an hour. One of the difficulties has been, and one of the concerns that has been raised, is that patients who come in with coronavirus might have sepsis because they're rather non-specific symptoms. The patient will have respiratory failure and be unwell, and until you get their swab results back, you don't know really whether it's sepsis or whether it's coronavirus. So most patients get treated for both in practice, is what happens, as is the case for other conditions. I don't know the specific test that you are referring to, Helen, I'm afraid, so I can't comment on that individually, but there are a range of biomarkers that you can detect in the blood which help to, for example, detect whether this person's likely, so there's something called procalcitonin, for example, which helps to detect whether the person is likely to have a bacterial infection, or whether, for example, they've just got an exacerbation of their COPD and their breathing's bad without an infection. And the tests like that are used quite a lot for antibiotic stewardship, so cautious and appropriate use of antibiotics. The reality is, at the point that a person comes into ED and they're really sick, you tend to cover all bases, and they're probably unlikely to have had a test done 3 days beforehand to inform where you are, if that makes sense.
That's been a magnificent tour de force, Hal, and a huge reminder of the fact that not only have we coped really well with COVID, but for a mid-sized district general hospital, it's best practice and good practice from start to finish, and is further reminder of the fact that we should be all humbled by the magnificence of the responsive view of your colleagues. So thank you. I'm going to come back to you, Tony, about this national record going to the GP, and have a look at the chat if you haven't already. I'm most impressed. Athol knows it's gone on his record, because not only did he have the test, he checked his record. And I'm going to find out how to do that. Very good. And Judith also knows that hers was sent. So maybe it's a bit patchy, but perhaps you can comment, Tony.
Yeah. Right from the start, in scaling up the testing capability across the nation, it has been a challenge. The emphasis has been first and foremost to test staff and patients in the various guises, and not a lot of attention from the national team in terms of how it is reported through the hospital systems and through into GPs. So in normal practice, you'd expect a request like this to come through your own respective GP. And what's been happening with all the pathology labs is they've had to work out, or try to work out, connections and connectivity back that way. However, depending on which route you go, and particularly the drive-through efforts and some of the national stand-up approaches, haven't got that connectivity back into the laboratory results files and then into GP files. So it is at the peak of COVID, it was a daily representation to the national lead teams that you really need to make that connectivity, which we didn't have a lot of success with. It still continues. The conversations are still ongoing. And for our own labs, and particularly the labs I coordinate across the Midlands footprint, is we're trying to build that infrastructure in. But it's a bit like building the bridge as you're walking across. And at the minute, we're walking across, looking back and saying, oh gosh, I've got a few bits missing. And one of them is exactly as I identified, the connectivity back to the GP.
Thank you very much, Tony. And last but by no means least, Sarah's kindly offered to give us the very latest thinking around visiting. So over to you, Sarah.
Thank you, Helen. I think the first thing to mention that's really important is that at all stages throughout the pandemic, we've supported compassionate visiting. So where there's been an end-of-life patient, a patient with a cognitive impairment or learning disability, for example, we have absolutely supported compassionate visiting on a risk-assessed basis. So the next steps are, as we open our services, balancing the operational risks that and challenges that Tony's described versus the clinical element that Hal's described in detail. with the holistic importance of that emotional support. So where we're at currently is a risk assessment of all clinical areas and departments to understand how many visitors at any one time would be safe to be enabled to be on site and in each department. Looking at the logistics of how we manage that, the volume that would create, and then working alongside our partner agencies and our partner trusts to make sure that we have a consistent message across the patch. Whilst we absolutely, if we don't agree with our partners, we absolutely will do the right things for our visitors, I think it's really important that there is a consistent theme, because we know that pathways of care go across our partners. So we're very nearly there. It will look different. It will be on a booked basis. And we also know that some visitors are reluctant to come in. So we have to balance that with giving the confidence to come in that we've risk assessed and we are safe to visit within those parameters.
That's been really helpful. Thank you, Sarah. And the first of many contributions to the Council of Governors and the board, I anticipate in your acting up role as Chief Nurse. So thank you for that. And we look forward to working closely with you over the coming few months. So that takes us, I think, through all the items that were raised at the Governor's pre-meeting, and I make no apologies for taking the time to go through that. It's really important. You're, you know, you've got the real up-to-date picture. And we'll go now, if we'll make item 9. So we're going to get feedback from Denise on the Joined Up Care Derbyshire Engagement Committee, and then we'll go to Margaret for the Involvement Engagement Committee, please. So Denise.
Thank you, Ellen. It's just really to update the council just about what it is. It has been going for quite a while, but obviously it's been suspended due to COVID. It was set up originally at CCG when the four merged, and it's all about public engagement and involvement. They've combined it with Joined Up Care Derbyshire, which is sensible. We really don't want to be looking at engagement around the CCG and then separately going to a meeting for Joined Up Care Derbyshire. So it was interesting that the last meeting, it's all around restoration and recovery. So they talked about obviously the CCG restoration as well as Joined Up Care Derbyshire restoration. One paper that they did produce was around an insight programme. And I think the Royal have been involved in this. When I've actually looked, the membership of it is NHS Provider Experience Engagement Leads, Helen. Obviously, the CCG place teams, and it's actually looking at things like a need to understand patient experience around virtual appointments, a need to understand the experience of the most vulnerable during the pandemic, looking at how people's expectations and behaviours have changed, like ED, because numbers went down, didn't they, in ED and things like that, about cancer referrals, a need to understand the value of community networks, and equally looking at capitalisation of the good that's been done and not losing all the innovations. And I think they're trying to do this rather than as a system, rather than survey the population, everybody, like hospitals and community and everybody. So I think they're trying to bring together from the CCG a uniform approach. So they actually went through some of the work that they're actually doing. It's quite an informative group. As I say, they meet monthly. And interestingly, it mirrored what Angie put in her report around Joined Up Care Derbyshire and what they spoke to us about. Obviously, going forward, you know, I'll just be doing it till Christmas. If I don't do it, Lynn does it, Lynn Tory. So the new, I would expect the new lead governor and deputy to actually be put into this, because I think it really is useful for the hospital.
That's been very helpful report back. Thank you, Denise. Does anybody have any questions of Denise before we move on to Margaret? No, just applause from Luke about the importance of the system working. So thank you again, Denise. Margaret, for the Involvement and Engagement Committee, please.
Hi, thank you. We had a meeting on the 22nd of June, and obviously there have been no ward visits to report, which would be one of our main topics, but we did ask Andrea Staley to come to speak to us, and she gave us a very comprehensive breakdown of how things have been in the hospital during the COVID, particularly from her perspective. I mean, a lot of it we'd heard already from the updates we were getting from Lynn, but it was really nice to get Andrea's perspective, and she answered lots of questions about things that had been done. So that was really, really helpful. We also had an update from Vicky Devlin around patient experience, and obviously what they were trying to do to capture some of the information, because obviously friends and family feedback has been limited. So she updated us on approaches that they were using to try and get some feedback. And then Simon Towers came to talk to us around all the excellent work that's been going on in terms of communication during the pandemic. And sadly, on the day, he had problems with the sound quality. So in the end, he actually sent us compiled a written report to send out to us to summarise everything. But it was just really useful to, and hopefully I think that, there might be some ideas of things that worked well in communications that we can keep going for, as engagement tools for us in the future. So that was really valuable. Obviously, the measures of success were endorsed, as we've mentioned already. And the only other item on the agenda was the Membership Matters newsletter, and we just had a brief conversation about topics for that. So it was very worthwhile meeting, I think. And we've got another one coming up next week. So that's it really from there. If anyone's got any questions, I'm happy to try and answer them.
Thank you very much, Margaret. It sounds like for a new committee, albeit with strong links to the legacy of PPI, it's working really well. Is there anything anybody wants to raise with Margaret?
It's not just to raise with Margaret, it's just in support of what Margaret said, Helen, in terms of Andrea's feedback. All the committee found it really useful, because yes, we have kept up to date from Lynn, etc. But from hearing Andrea on the ground, it was absolutely excellent. I think we've lost Ellen.
Yes, I mean, I endorse that. It was really an excellent session, and we were very grateful to her to have given us the time.
Apologies, Denise, I missed that. I am temporarily dropped out. I think we might be doing the same thing again. Oh, there we are. But it sounds like you were saying how useful it was to have Andrea there, which I know you've said to me already. So I'm really pleased that she made the time to be with you.
And I think if Sarah could pass that on to Andrea, we did say thank you, but it just brought it on to us actually, how it's been for the staff and people.
I've no sound.
Oh.
I think we may be able to hear you, Helen, still. Maybe not.
Hello again. Can you hear me?
Yes.
Yes, we can.
Little glitch in the system there. Yes, thank you for that, Denise and Margaret. that brings us, if we may, please, to the Cog Evaluation. I'm happy to speak to this, Gillian. I know I'm down the paper to speak to it, but I was anticipating you might want to position the paper.
Yes, that's fine. I'm happy to do that. Thank you. Good afternoon. As the paper sort of describes, this is about the Nominations Committee's consideration of the 2019 evaluation, and also the actions that have come from that evaluation since then, and also it looks at the recommendations for the evaluation for 2020 as well. So the Nominations Committee did look at the whole evaluation, and they looked at all the benefits that had gone from that interactive session that you had last year, using the voting, if you remember. They felt that it was very open, the very positive feedback had been given, and it allowed some real good, deeper discussion as well. The actions that you've got in the annex as well to the report sort of describe what's happened since then. There's just one thing that I wanted to highlight to you was around the stronger links with membership. Just to say that the membership strategy in draft is coming to the board next week, so it's just a little extra update there. In terms of going forward for next year, what we are recommending is another interactive session with a slight difference, giving an opportunity to executives to have slightly differently worded questions. So allowing the governors to have a session and then bringing the execs in towards the end. And again, an interactive session. The most likely thing is that it will be a remote session like this, but we're working on the technology to make sure that goes really well. Thank you.
Thank you very much, Gillian. I think it's a very comprehensive proposal, building on all the strengths of last year's process and adding a few bits. So, you know, I'm certainly get great value out of it. Colleagues have had a chance to hear Gillian's description and also to read the paper. Can I ask if you are content to proceed on that basis? Seeing a nod from Denise?
Yes.
Yeah. Okay, thank you very much. Well, let's do that then, and we look forward to October, Gillian. Thank you very much. So that brings us on to the consent items. We haven't had consent items to the best of my recollection of the Council of Governors before, but for about the last 2 months, definitely since lockdown, we've been using them to great effect at the Board of Directors. For two purposes, really. You know, when you're working virtually and you have to keep saying to people, would somebody agree the minutes, and you know, these procedural things you need to go through, but you're kind of having a conversation with a bit of a black hole, and it takes a lot of time to not much avail. So it's a good way of dealing with that, but it's also a good way of dealing with things where there are decisions to be taken or agreements to be reached, and the item requires something beyond just noting. So it's not an information item. It's an item that is being agreed or approved or whatever the recommendation is, but is not being discussed at the meeting. And if there is to be any discussion at the meeting of a consent item, it needs to be flagged up in advance. So when you read your papers and you think, oh, I'm not happy for that to be by consent, actually I want to raise a question or a query or a challenge, whatever it might be, you indicate that. And if you indicate it, that allows us to take time to come to the consent item. But it does allow us to do a lot of business, and it's particularly helpful where, for example, as a board, we're completely content that, for example, a particular committee have given this issue the right level of scrutiny, and the rest of the board are happy on that basis to approve an item or something. That'd be a really good example of it working well. So we thought we would try it in this context. I did shiver slightly when I put the performance update in the consent items, for fear that you thought we were trying to kind of remove or restrict the opportunity to ask questions on that, which is why we were very particular on the agenda to indicate that if you did want to raise anything, that, you know, that item earlier on the agenda and looking at governor measures of success, item 6 was a good opportunity to range far and wide. And of course, you know, we're always happy to take any questions of that nature under that. So I haven't had any indication in advance that anybody does want to raise any issues on that, on these items. Having said that, it is the first time we've used a consent item and you haven't had the benefit of that explanation before. If anybody does want to raise anything, I'm very happy to take it now.
Ellen.
Yes, please.
You raised something in the chat box earlier on about pressure areas and pressure sores, and I don't know whether that was answered. Was it answered, Luke?
No, I'm not sure because I had to disconnect momentarily. I had IT issues. However, what I just wanted to check, it was in the performance update, and it was related to pressure ulcers, and I think it was April where we saw some special cause where it jumped higher than the upper control limit. In the explanation, it sounded like that was simply to do with positioning of COVID patients, but I just wondered whether we could have assurance whether that was just the case or whether there was something else.
Okay. Sarah, could we ask you to come in on this, please?
Sorry, I haven't got the detail in front of me, but I believe that was to do more with the acuity and the case mix of patients that we were seeing coming through. So it's perhaps how we describe that in more detail in the narrative that goes alongside that.
Okay. So
Okay,
if there's any explanation other than the one that's been provided, Luke, we will include that in the response to the items in the usual way.
Thank you.
Thank you very much. And that moves us on to any other business. Are there any items of AOB? Just give you a moment.
Helen, can I just raise one thing, if that's okay? I just wanted to say that we last week held the nominations for the lead governor who will replace Denise when she reaches the end of her term this year, and we've received 2 nominations from Margaret Rochelle and Norman Shaw. So thank you for those nominations. Voting papers have gone out to you all today, and we've got until the 5th of August for you to cast your votes, and then I'll share it with the full council.
Thank you very much, and particular thanks also, of course, to both Margaret and to Norman for agreeing to step forward. That's very good. So that then concludes AOBs for us. You've got a couple of items there for noting. The next meeting is going to be on the 23rd of September, which does seem like a long time away, but the date's there for noting. We don't know whether we'll be in the flesh or remotely, but I think it's as well that we're prepared to conduct business on Teams. And
thing again, I couldn't say anything because you'd unmuted it.
Oh, I think we're having a bit of IT problems in the Lion household. So that brings us to the review of the meeting. Before I invite comments, I'd appreciate if Kate could tell us if any members of the public did join. The last time I checked whether we hadn't got any, or maybe Gillian can also see, and if we have any, and if we've had any questions, that would be helpful clarification in a moment. And Denise has helpfully reminded me that in addition to the full Council of Governors meeting in September, of course, we've got an update planned for August. So thank you for that. It's difficult to go around the table, isn't it? But may I perhaps go to you first, Denise, to ask for reflections on today's meeting?
I think it's gone very well, as usual. I think we before time, so that's always a bonus. And I think we've had enough time to discuss the issues. So I think it's gone exceptionally well.
Very good, thank you, Denise. Any other comments on today's meeting? Well, we'll have to take that as people are satisfied, or I'm sure they would. I'm sure they'd tell us the other thing. not backwards in coming forward in that regard, and some helpful feedback on the chat. So thank you for providing that too. All it remains to say is thank you for your time today. Renewed thanks to everyone at the Trust for what they're doing in very difficult circumstances, and the thought and ambition that's been shown about restoring services across the board. And it was really good to hear some first-hand account of all of that. I bid you farewell. Take care.
Thanks a lot. Bye.
Thanks, Helen.
Bye.
Bye everyone.
Bye everyone.